Greetings to all of you. My name is Dr. Njambi. I'm a pediatric ophthalmologist and a lecturer at University of Nairobi. I'm glad to be here today to present on pediatric ophthalmology. Our topic of discussion is what every pediatrician needs to know in pediatric ophthalmology. This is a broad topic, so for today we will highlight some of the common eye conditions that we see in children. I have no conflict of interest to declare, and this CME has been prepared on behalf of the Kenya Paediatric Association and has been sponsored by an educational grant to KPA by Pfizer. To start with, I'll report on findings of a study published in Journal of Ophthalmology of East, Central and Southern Africa that was done in 2013 on knowledge, attitude and practice of eye diseases in children among pediatricians in Kenya. The primary author, Dr. Wanyama, found out that though the attitude and practice in pediatric ophthalmology was positive, the knowledge of the participants needed to be boosted with regular continuous medical education. So we hope by the end of today we'll have boosted the knowledge level. So our outline will look at the visual development in children. We'll define amblyopia before we go on, because this is a term you're going to use quite frequently in the presentation. We'll look at the pointers to poor vision in a child and highlight some of the common childhood eye conditions, how to identify and how to treat them. And finally, we will look at visual screening. So to start with, we'll look at the cross-section of the eye. The first figure 1 shows the parts of the eye as we're going to use them in the presentation. The front part is a clear part of the eye is the cornea, which extends posteriorly as a sclera, and this forms the protective layer of the eye. On the inside we have the lens, the crystalline lens, and at the aperture that in front of the crystalline lens is the pupil. The uvea is composed of the iris, ciliary body, and the choroid. The neurosensory part of the eye is the retina, and it has some sensory nerves that continue as the optic nerve up to the brain. Figure 2 shows a fundoscopic view of the retina. This point portrays the optic disc, and the little dot here shows the fovea, which is the most sensitive part of the eye in terms of vision. In terms of normal development in children, pupillary reflex develops quite early, and by 30 weeks of gestation, the babies have pupillary response. Most of the visual functions develop between birth and 4 months of age. Of note is that the central visual system, that is from the optic nerve up to the visual cortex, continues to mature up to around 7 to 8 years of life, and this is a period we call critical period. It is very important because visual impairment in this period, if it is not managed properly, can lead to permanent visual loss. And this brings us to our next slide, where we are going to briefly discuss amblyopia. Amblyopia in layman's language means lazy eye. And it basically means a physiological central visual loss due to stimulus suppression. What this means is that for eyes to continue developing normally during the critical period, you need stimulus of good integrity and almost equal integrity in the two eyes. If for any reason the integrity of visual input from one eye is affected, the eye with the poorer images get suppression, and if this continues and it is not addressed on time, it leads to the permanent visual suppression, which we call amblyopia. Some of the conditions that can cause amblyopia include strabismus, and in this case the suppression occurs because one eye is deviated outwards or inward and therefore doesn't give clear images into the brain. The second common cause of amblyopia, we call it deprivational, and this occurs if there is any organic disease such as ptosis, cataract, or corneal opacity that prevents light from entering into the eye. And the other common cause of amblyopia is refractive errors, especially if you have different refractive status, so that the eye with the poorer vision gets suppressed, or if you have high refractive error in the two eyes, the input is blurry and therefore you still get amblyopia. About treatment of amblyopia, it must be done within the critical period. The development of amblyopia and treatment must be happens within the critical period. That is the first about 8 to 10 years of life. And what is very important is you must remove what is predisposing to amblyopia. So if there's strabismus, if there's a cataract, it must be treated. And the next, the definitive treatment is to penalize the better eye, as shown in figure 3. And there are various options of penalizing. You can either patch the good eye, as shown in this patient, and so that you stimulate the eye with the poorer vision to develop optimal in terms of vision. Other options include using atropine and fogging, but the principle is the same, is that you encourage the eye with the amblyopia to be used more than the good eye, and that stimulates the normal visual development, as long as it is within the critical period. So what are the pointers to poor vision in a child? Some of them can be very obvious and others can be quite subtle. So some quite obvious signs of poor vision in a child include squinting, as shown in figure 3, or holding objects close to the face, like in figure 4. Other things include moving closer to TVs or screens. And for the older children, you can have them complaining about blurry vision or feeling of tiredness in the eyes and headache. Now, for the subtle signs, which may be harder to pick but very important, because they may be the only sign that you have to indicate that the child has poor vision. One of them is poor attention span in terms of visual activities. The other thing is avoiding near tasks, because they get fatigued quite often, so the children will try as hard as possible not to do near tasks such as reading and any other activities that include that are done at near distance. The other thing is losing track while reading books or other gadgets, and the other important sign is turning the face sideways, shown in figure 5, and closing one eye to read, as shown in figure 7. Sometimes you even have abnormal head positions, like in figure 6. Others include sensitivity to light and tearing. There are some conditions that in themselves they are indicators of poor vision, and one of them, and very common, is albinism. Because of the poor pigmentation in the retina, most of the children will have poor vision, and they'll also have refractive errors. The next condition we'll look at is refractive errors. Now, important to note is that it's the commonest cause of visual impairment, and this occurs due to improper focusing of the rays on the retina. So one could either be short-sighted, like in number one, where this is called myopia, and in this case the rays are focused in front of the retina. The other refractive status is hyperopia, as shown in number 2. In this case, the rays are focused behind the retina, and the third refractive status is astigmatism, which can either occur alone or in combination with myopia or hyperopia. So, as we had said before, refractive errors, if not treated, may cause amblyopia and is a common cause of poor performance in schools. And correction is mainly using spectacles and contact lenses, and this can be done in even very small babies, and should be done promptly so that you're able to correct the visual problems in time. Our next condition is allergic conjunctivitis. This is a very common eye problem, and especially when it is recurrent, such as in perennial and atopic and vernal conjunctivitis. Some of the signs of allergic conjunctivitis include conjunctival pigmentation, as shown in figure 10. Sometimes you have swellings around the junction of the cornea and the sclera, which are as a result of lymphoid follicles. And on eversion of the eyelid, you can have these bumps that are called papillae, as shown in figure 12. And in persistent cases where the allergy is not treated, you have the papillae eroding on the cornea, resulting in a corneal ulcer, which is called a Schill's ulcer. Of importance to note is that allergy can lead to serious complications. Most of children with allergic conjunctivitis have refractive errors, and as we have said, you can get corneal ulcers and scarring. It also predisposes to viral keratitis, that is a viral infection of the cornea, and because of repeated rubbing from the allergy, it can predispose to a very serious condition called keratoconus. And this occurs when the cornea, because of too much rubbing, the cornea thins out and bulges out, and this, if it's not addressed in time, can lead to perforation and scarring. Our next condition is strabismus. Strabismus mainly means crossed eyes or malalignment of the eyes. In the normal circumstances, we have the eyes having symmetrical alignment, as shown in figure 14, where the reflexes on the cornea are central. Like in figure 14, you have the reflex there, and the reflex in the left eye, they are quite central, and the eyes are straight. In instances when you have strabismus, the eye either deviates outwards, like in figure 15, you have the right eye deviating outwards, and this is called exotropia. Sometimes you have the eye deviating inwards, like in figure 16, and this is called esotropia. And there are cases the eye deviates upwards, and this is called hypertropia. So what are the causes of strabismus? Most of the strabismus we see in children is congenital, and this is caused by motor and sensory imbalance at the level of the brain. There are other causes of strabismus, such as when you have sensory deprivation, like in cataract. Apart from causing amblyopia, if the eye remains in poor vision for long, because it's not processing images into the brain, it finally deviates outwards. Other causes are refractive errors, trauma, nerve pulses, neuromuscular diseases, and retinoblastoma, which you're going to highlight in the next few slides. Consequences of strabismus. Most people feel like strabismus is a normal thing and doesn't need to be treated. But of importance, as he had said before, it can result in amblyopia, and if this is not treated in time, you get permanent visual loss. The other complication of strabismus is a loss of depth perception. For one to develop depth perception, you need the two eyes to work together. So in case one is deviated, then one is not able to develop the stereopsis, or what you call the 3D vision. The other thing is that refractive errors can cause strabismus, as we have said, and strabismus can increase the chance of refractive errors. And finally, and very important, is that the cosmetic and psychological effect strabismus has on children, especially when they're adolescents. It can be quite devastating. So treatment of strabismus involves you treat the cause if it can be identified. The other thing is if there's any amblyopia, it must be addressed. In case of refractive errors, spectacle correction, and the definitive treatment for strabismus is surgery. So figure 18 shows a child who has strabismus. We have the outward deviation of the left eye as shown in the picture, and this child also has refractive error. So our next condition of discussion is leukocoria, which means a white reflex. There are many causes of white reflex in children, quite a number, but today we'll look at the three commonest and probably what is very common and important in our setup. So we start with cataract. Cataract means opacification or haziness of the lens. Most of the cataracts in children are either congenital or developmental, but we have quite a number as a result of infections, especially the torches, and metabolic disorders. Other causes include hereditary factors and trauma. So for cataract, what is very important is because it is opacification and affects light entering the eye, as you had said before, it will predispose to amblyopia. And the other thing is that you need prompt treatment as soon as the diagnosis is made, regardless the age of the child. Spectacle correction after cataract surgery is a must for all the children, and if there is any amblyopia, which is almost always present, needs to be addressed through the methods we had highlighted before. So figure 19 shows a child with bilateral cataract, and this child also has strabismus. There is inward deviation of the right eye as a result of cataract staying for very long before intervention. Figure 20 shows early cataract, which is at the center of the lens, which you call the nucleus. If this is not managed early enough, it would progress to involve the whole of the lens. Figure 21 shows a child who has had cataract surgery and is now having spectacle correction. The next very important cause of leukocoria is retinoblastoma, and this is a cancer of the eye that affects children. Most of the time the children are less than 5 years, but we've had cases even teens have presented with retinoblastoma, and it results from the mutation of the RB1 gene, which is a tumor suppressor gene, and the mutation can either be somatic, meaning only occurring in the eye, or it can be germline. That means it's present in all the body cells. And this is important because if the patient has a germline mutations, it means they have risk of other second cancers that may occur later in life, and sometimes there's a family history. What is very important about retinoblastoma is that you need prompt referral in order to save life. And in many cases, one may not be able to tell whether the white reflex is from the cataract or from the retinoblastoma. So what is very important to note is that any child presenting with a white reflex needs urgent referral so that they can be evaluated for either cataract, retinoblastoma, or any other condition that can cause leukocoria. There are various treatment options for retinoblastoma. In our setup, because our children present late, enucleation is the standard treatment, which involves removal of the eye. Other modalities include chemotherapy, radiotherapy. For the cases that present early, we can have local treatment, which includes laser and cryotherapy. Apart from the treatment itself, it's very important that the child undergoes regular examinations under anesthesia, because once retinoblastoma develops, there can be a risk of getting other tumors. And also genetic counseling is very important, because the offsprings of the patient may get later in life may also get retinoblastoma, and the siblings, especially where there's a family history, may also get retinoblastoma. Some of the other ways in which the retinoblastoma presents include strabismus, like in figure 23. Figure 22 shows the leukocoria in retinoblastoma, and as I've said, it may be very difficult to differentiate this leukocoria from the one of the cataract. So any child who has leukocoria, it's an emergency and must be referred promptly. Other ways of presentation, sometimes you have chronic redness of the eye and hyphema, which is the blood in the anterior chamber. In advanced cases, you get the tumor growing outside the eye into the orbit, which results into eye protrusion, or what we call proptosis. As I had explained before, there are various treatment options. The standard treatment for us is enucleation, and this boy in figure 1 has had his right eye removed with implant and prosthesis in situ. And for all those children who have one eye for one reason or the other, they must have protective eyewear all the time to prevent injury to the remaining one eye. Figure 2 and 3 show early stages of retinoblastoma, and these are the cases where, if found, you can be treated using laser or cryotherapy. And figure 4 shows regressed tumor, where the tumor masses have been treated and what is remaining now are scars. There is no active tumor. So the third and also very important cause of leukocoria is retinopathy of prematurity. This is becoming quite common with improved neonatal care. And retinopathy of prematurity occurs in premature babies, those who are less than 1,500 grams, or those who have been born before 32 weeks of gestation and have had supplemental oxygen, and those who have neonatal complications. As a result of supplemental oxygen, it results in stimulation of vascular endothelial growth factor in the premature retina, which results in abnormal vascularization as shown in figure 2. And because the abnormal vessels come with a fibrous membrane, this exerts traction on the retina, which leads to retinal detachment. And it is the retinal detachment that results into leukocoria. in advanced cases. So to prevent or to be able to diagnose retinopathy of prematurity early before retinal detachment occurs, what is very important is that every premature baby who fits into this, the criteria, that is less than 1500 grams, and was born before 32 weeks, has had oxygen, and has had neonatal complications, needs to have eye screening around 3 to 4 weeks after birth. Not immediately after birth, but about 4 weeks after birth, because it has been shown that it takes about 4 weeks for the abnormal vessels to start developing. And in the early stages, if early ROP is diagnosed, interventions such as laser or cryotherapy or injection of antivascular endothelial growth factors into the eye can be done, and this has been shown to retard the progression of retinopathy of prematurity into the advanced cases. Figure 28 shows the retina of a child that has been treated with laser. These small dots, those are laser marks after treatment of retinopathy of prematurity. Now, if this is not addressed in time, then you get now the retinal detachment, as I had explained, and this, so a sign of white reflex in a child with retinopathy of prematurity is a bad sign, because it shows that the disease is in very late stage and the treatment outcome is variable. So the best time to intervene is before you get the retinal detachment, and this can only be done if there is eye screening that is done starting 4 weeks from birth. Apart from retinopathy of prematurity, preterms are at risk of other ocular complications, which include strabismus, refractive errors, glaucoma, cataract, and nystagmus. Therefore, even if a child did not fit the criteria of being screened for ROP, they still need to be referred to the ophthalmologist for evaluation for the other complications that may occur. So our next condition to look at is glaucoma in children. Glaucoma mainly refers to high pressure in the eye, causing optic nerve damage, and this results in irreversible blindness. Glaucoma in children can present either at birth or later, and usually it has a triad of presentation where the child presents with photophobia, tearing, and a lot of blepharospasms. They are not able to open their eyes, and they keep their eyes tight shut because light really hurts them. Other signs that can be noted is you have big eyes or big corneas in the early stages, as shown in this picture, the first picture. And if this is not addressed in time, you get the eye becoming very hazy and opaque. Other complications that can occur because of glaucoma is you get short-sightedness, and the lens can also get dislocated. Of importance is that children with glaucoma needs urgent referral, and the treatment for glaucoma in children is surgery. For adults, sometimes eye drops are used, but the ultimate treatment for glaucoma in children is eye surgery. A very important differential diagnosis in glaucoma is nasolacrimal duct obstruction, where babies are born with incomplete opening of the nasolacrimal duct and may present with a lot of tearing at birth. But the main difference between glaucoma and nasolacrimal duct obstruction is that in glaucoma there is the photophobia and the blepharospasms plus the tearing, as I had explained. But in nasolacrimal duct obstruction, the the child is fairly comfortable. Apart from the tearing, the child is very comfortable. There is no photophobia, and the size of the eye is within the normal for age, as opposed to glaucoma where the cornea and the eye may be big. There are some systemic conditions that are associated with glaucoma, and a very important cause is Sturge-Weber syndrome with the port wine stain, as shown in this child. In this case, the patients get unilateral glaucoma on the side with the hyperpigmentation. So there are some, for example, if a child has Sturge-Weber, or even a patient, this is someone who needs evaluation for glaucoma, even if they initially don't present with signs and symptoms of glaucoma. Our next condition is vitamin A deficiency. Vitamin A deficiency in the eye is called xerophthalmia, which basically means dryness of the conjunctiva and the cornea. Of importance is that it presents quite early, initially with night blindness, which now later progresses to dryness of the cornea and the conjunctiva. And if this is not addressed in time, leads to cornea ulceration and the melting of the cornea, and eventually scarring. The risk factors is especially children with measles and those who have malnutrition and malabsorption. Treatment involves treating the cause, that is the deficiency, with supplements and food rich in vitamin A. Immunization, especially against measles, is very important. Initially, when there is night blindness and the dryness, treatment can result in reversing of the symptoms, but when this is not done in time, then you get the complications of melting of the cornea and the scarring. So these are pictures showing a patient with vitamin A deficiency. Figure 30 is showing conjunctival dryness and bitot spot, as shown here. Figure 31 shows bilateral scarring of the cornea. This is after the extensive cornea melting as a result of the deficiency, and eventually heals with scarring. And figure 32 is an example of foods that can be used in vitamin A deficiency, which include carrots, eggs, and vegetables. Our next condition is ophthalmia neonatorum. Ophthalmia neonatorum is conjunctivitis of the newborn that occurs within 30 days of life. There are various causes, but the commonest cause in our setup is Neisseria gonorrhea. Other organisms include chlamydia, viruses, and even traditional eye medicine that are toxic to the eye. The classical presentation is swelling of the eye plus a lot of discharge, especially if there's if the cause is Neisseria gonorrhea. This, if it is not addressed in time, because Neisseria is one of the organisms that can penetrate an intact cornea. If this is not addressed in time, it can result to corneal melting and perforation of the eye within a very short time. So treatment needs to includes frequent eye irrigation to remove the copious discharge, and using antibiotics. And the antibiotics that are used must be a combination of both topical antibiotics that is applied to the eye and systemic antibiotics. None of either can work alone. Topical antibiotics cannot work alone, and systemic antibiotics don't reach the eye in very good proportion. So you need the combination of both the topical antibiotics and systemic antibiotics. Prevention involves good antenatal care, because part of the risk factors include untreated sexually transmitted diseases, prolonged or poorly managed labor, and contamination at delivery. So good antenatal and delivery care is very important for prevention. The other thing is use of antibiotic eye drops at birth. The commonest that is used in our setup is tetracycline, and of course good labor management. So our next condition is cerebrovisual impairment. Now, cerebrovisual impairment refers to visual loss resulting from organic brain damage. So any conditions that cause organic brain damage, such as hypoxia, and in our setup the commonest cause of hypoxia is birth asphyxia, infections such as meningitis and encephalitis, and neurological conditions, hydrocephalus, and some metabolic disorders can result in poor vision. And therefore it is very important that children who have such predisposing conditions, especially those with history of birth asphyxia and cerebral palsy, they must be referred for eye examination. Treatment of cerebrovisual impairment involves you treat the underlying cause if it's possible, and visual stimulation. The poor vision in cerebrovisual impairment is most times very advanced, and therefore the response also depends on how much damage, brain damage, has occurred. So the outcome is also variable, but treatment involves visual stimulation using light, like from a torch as shown in the picture, and using bright colored objects, and especially those that have dazzling light. You stimulate the eyes, and based on the plasticity of the brain, you're able to stimulate some of the nerves and recover some of the vision. And on top of cerebrovisual impairment, there are also other ocular conditions that the patients must be evaluated for, and this includes strabismus, refractive errors, and nystagmus. So finally, a note on visual screening. The international recommendations on visual screening indicate that this should be done in neonates. So as soon as a child is born, they should have their eyes examined, and at around 6 months of age to about 1 year, you should have the next screening if there's no condition or problem noted. And thereafter, just before they join school at 3 years, and when they're school going, you should have annual visual screening. This happens in some countries like UK, where they have established systems, but in our setup we don't have very standardized visual screening. So very important, we were able to include a visual screening tool in the Mother and Child Health booklet that was added in 2010, and this is supposed to help health workers to identify some of the conditions that we have highlighted in the presentation. And what the page requires is that the health worker checks or confirms that the child gets tetracycline at birth, and also examines the pupil. And when you examine the pupil, what you're looking for is either whether the pupil is black or white for white reflex, assessment of sight based on age, and here you'd use some of the pointers we're talking about of poor vision, and also using the normal development for the eye to see whether the child is able to use the eyes as per age. Squinting, there's a picture on squinting. So in this case, the health worker will be looking whether the alignment is straight or the eyes are deviated. And the last thing is that if there's any other problem, including a complaint from the mother, the child should also be referred to the ophthalmologist. So in summary, visual impairment during the critical period can lead to permanent visual loss for the rest of life. and therefore it is important to perform a visual assessment and a comprehensive eye examination with every child. And we should also ensure that to screen all children with any sign of visual impairment, and especially the premature infants, those with neurological problems such as meningitis or any other sign of any other child with signs of poor vision or eye issues. They need to be screened and referred promptly. Thank you.